It is a real exciting development here for the University of Wisconsin program. Its goal is really to conduct interdisciplinary and the translational research that really exploits some of the strengths we have here and our national connections to improve outcomes for patients with prostate cancer. This SPORE is really going to align our strengths in basic research, and we have a huge campus where there are a lot of outstanding investigators with individuals that are working clinically to provide new avenues of care for men with advanced prostate cancer.
Hello and welcome to our WInnovations webinar turned podcast series. I'm your host, Dr. Kyle A. Richards, and we have a really superb program planned for today. The purpose of these podcasts is to highlight exciting and innovative work being done at the University of Wisconsin Department of Urology. And we also want to generate a broader discussion within the urology community so that we can continue to all work together to make innovative advancements in urologic care. We're also rolling out a urology joke of the month, so stay tuned for that. That'll be coming at the end of my discussion with our guest. So please don't fast forward to the end just for the joke of the month. You got to listen to the entire podcast. So now, with no further ado, I'd like to introduce our distinguished guest for this morning, Dr. David Jarrard. Dr. Jarrard joined our department in 1996 after completing his fellowship training at Johns Hopkins University in Urologic Oncology. He did his residency in urology at the University of Chicago, where I also did my fellowship, so we have that connection. He's the Vice Chair of Clinical Affairs and holds the John P. Livesey Chair in Urologic Oncology. He's also the Deputy Director of the UW Carbone Comprehensive Cancer Center. In addition to his busy clinical practice focused on prostate cancer, he does conduct clinical, translational, and basic science research related to prostate cancer. And I know he's very passionate about our topic for today, which is novel approaches to prostate cancer therapeutics. Dr. Jarrard, welcome to the program.
Thank you. It's a pleasure to be here, invited to WInnovations. I think this is a really exciting time in the prostate cancer field, and hopefully we can work in a joke or two before the end even.
Yeah, we gotta keep it pretty light, and I've been working with Dave for the past almost 9 years now since I've been here, and I've really enjoyed his mentorship, his sense of humor, his friendship, and I remember when I first started, I would always say, Dr. Jarrard. He's like, "You're making me feel old. Call me Dave." So first off, Dave, how did you get interested in prostate cancer as sort of a focus of your, clinical practice, research, et cetera?
Yeah. When I think back, it really was actually, we had a close neighbor who had the disease, and this occurred when I was in medical school. It sort of got it on my radar at that point. He ultimately succumbed to his disease. When we began learning about this in medical school, there were a lot of unclear questions. It was, it seemed that the field was really misunderstood. Everybody gets prostate cancer, but no one dies of the disease. That was sort of the mantra. Actually, when I was in my fellowship training at Johns Hopkins, I had a mentor, Don Coffey, who said that if you could find a question you're interested in, and it's a good one, you can make a career of it. So that really, the question I landed on was, there's this remarkable prevalence of the disease in aging men. And if you look at men as they get older, about 70% of men will have microscopic evidence of disease in the prostate. And the question is why? And why do you get some disease that becomes more aggressive and creates an issue, other disease that just sits there? So this had a lot of implications with regard to how to better detect and treat the disease. And at least at that point, and even today, there's a lot of room to run regarding improving the care of our patients.
Yeah, I heard you talk about a personal experience with a neighbor and how that impacts you and your career. I think those personal experiences are key. And then also having that mentor early on, right? Don Coffey at Johns Hopkins, they really helped to sort of stimulate that creative thought and that quest for answers. And I know prostate cancer is so highly prevalent, as we know. So when you're in clinic seeing a new patient with prostate cancer, how do you begin that discussion? And obviously you individualize the discussion based on each individual patient, but how does that discussion go? And what are some of the things that maybe those newly diagnosed patients with prostate cancer are most worried about?
I think one thing to emphasize is that prostate cancer is unique. I will often state that this is not lung cancer, it's not pancreatic cancer. With regard to growth rate, even in these more aggressive variants, it's a slower growing disease. One question we always address with patients is observation of choice. Could this be something that could just be monitored? We focus on really fully educating the patient and talking about both treatment and non-treatment. We have certainly here and in many centers in the country, multidisciplinary groups that can deal with sort of more complex cases. Nutritional counseling is also an important part of cancer care, and that's something we'll expose patients to. But this issue of education is really something we highly prize here, and we'll typically have most of our patients meet with radiation therapy, surgery, to talk about all the various options. I think it's important also just to be aware of the internet. It can be a real vortex when it comes to information, but sticking to reputable sites, the National Cancer Institute, certainly our website here is a good opportunity to better educate yourself regarding this disease.
One of the, I think, key points you made that I think is so true is the multidisciplinary care of men with prostate cancer is something that's really unique at many comprehensive cancer centers, but certainly at the Carbone Cancer Center here at UW. I'm a prostate cancer surgeon like yourself, and I totally agree. Getting these patients in to see radiation oncology, medical oncology, urologic oncology. We have multidisciplinary conferences to talk about some of the more complex patients. I think that's definitely a unique aspect. One thing that I think also is interesting is, where does primary care come into play with prostate cancer, right? Because, that's something that we haven't really touched on yet, but a lot of patients, they make it to our clinic via referrals from primary care for prostate cancer screening. And that really became a hot button topic in 2012 after the U.S. Preventive Service Task Force recommended against PSA-based screening. And then, they sort of toned that down a few years later, but that had a huge impact in the primary care world. Can you just talk a little bit about how that impacted our patients?
Yeah, I certainly empathize with our primary care colleagues. They're getting a little bit of whiplash with regard to PSA screening and trying to understand it. I actually was giving a talk last night, and invariably the question becomes, how do I counsel my patient at this point? Obviously the primary care physicians are the individuals who know these patients the best. But there's some data that has recently become evident that I think points to the importance of PSA screening. And obviously PSA screening has remained controversial because of this risk of overdiagnosis and overtreatment of especially low-risk prostate cancer, which can certainly outweigh the mortality reduction resulting from high-risk disease. And as you mentioned, the U.S. Preventative Services Task Force initially in 2008 had recommended against routine PSA screening for men older than 75. In 2012, following some data that became available through a large screening trial here in the United States, they followed that up with a recommendation against screening for all men in 2012. And the question is, what happened next? And unfortunately, we're beginning to see the results of this decrease in screening. And screening rates dropped about 30%. I think in many respects, that was a good thing. A lot of patients were not necessarily benefiting from PSA screening. Much older patients with a lot of other health issues. But on the flip side of that, there were patients that could have benefited. So there's a large database, it's called SPORE, which looks at multiple institutions across the United States. And there's been an increase in de novo metastatic prostate cancer diagnosis if you look from 2011 to 2018. And this data only goes up to about 2019 at this point. We don't really have data over the pandemic. obviously that it's going to take a few more years to collect that. But what we're seeing is an increased risk or increased rate of prostate cancer metastatic detection for men between 45 and 74. And again, that's sort of your population that you're wanting to focus on. It's increased about 39% over that time period. This is also, we're seeing an increase in the prevalence of locally advanced prostate cancer at the same time. And this, to a certain extent, validates what we've been seeing in clinic over the last couple of years. More of these men are coming in with much more advanced prostate cancer. I think certainly one thing to emphasize is that these patients that are more advanced when they come in, it's more of a challenge, especially with metastatic disease. The average survival of a patient with metastatic disease, 5-year survival is about 40%. So even though we've made remarkable improvements in our treatment, these patients actually will have, again, a more difficult time with regard to management.
Yeah, those are all really good points, Dave. And I think, the U.S. Preventive Service Task Force had good intentions, but there certainly are some downstream consequences of some of those recommendations that had been made that we're now seeing, years later with more advanced prostate cancer. And I agree. I feel bad for the primary care physicians because they're kind of put between a rock and a hard place trying to counsel their patients. And, I think we had an over-treatment problem that sort of led to all this. It's unfortunate that it came to this, but hopefully we'll see the pendulum swing back. And, because as you pointed out, treating metastatic prostate cancer is very challenging, and there oftentimes is not a cure.
Yeah. I was also going to mention, we haven't really seen the increase in mortality rate yet. That's something that we're expecting given this more advanced stage. But it's important for people, patients, and also our primary care docs to realize that prostate cancer remains the second leading cause of cancer death after lung cancer. I was talking to a colleague of mine in cardiology the other day, and he said 30 years ago they were treating heart attacks, acute cardiac issues. It's completely changed now to more valve disease and failing hearts, in part because we've gotten so much better at preventing heart attacks. So cancer is the number one cause of death in men in their 60s, and that's going to be an issue moving forward. Increased longevity is definitely associated with increased risk for prostate cancer. So there will be potentially this uptick in mortality. We're expecting to see this. Certainly, over the last 25 years since PSA screening was initiated, it's been about a 54% decrease in mortality, but that has really flattened at this point, and we're beginning to see an increase in deaths in some of these populations. So hold on to your hat.
It'll be interesting to see as that survival data kind of comes out down the road. And sort of along the same themes as more advanced prostate cancer, there's 2 points I wanted to sort of touch on. One is neoadjuvant therapy, because that's sort of a hot topic geared towards patients with advanced prostate cancer. And then the other was, so maybe we'll come back to that, but a little foreshadowing there. But the other is looking at combination therapy for patients that are receiving androgen deprivation therapy. Can we find a therapeutic window? Or, you and I worked on some studies looking at synthetic lethal metabolic targeting of these senescent cells after androgen deprivation therapy. So can you explain sort of the rationale for this strategy for people that aren't as familiar with, sort of senescent cells and how this might be applied for these patients with prostate cancer, specifically more advanced disease?
Yeah, I know we had some really interesting data that we generated using some of the health sciences research you do, and then actually reinforced much of this with our translational work as well. It's important to understand this with the history of prostate cancer treatment, and it was back in the 1940s that Charles Huggins actually discovered and reported in a landmark paper this androgen sensitivity of prostate cancer. And this has basically been the sole treatment of advanced prostate cancer for the last 60 plus years. He won the Nobel Prize in 1966 for this. But since that time, it's been recognized that it works for a while, that when you expose prostate cancer to androgen deprivation, some cells will apoptose, necrose, and die. Some cells will sort of undergo a mitotic arrest where they're just sitting there, and others will enter a state of senescence where they're essentially irreversibly arrested, but they produce products that can actually promote the growth of these other cancer cells that remain. So this is really based on this theory that maybe there might be susceptibilities that androgen deprivation therapy generates that we could take advantage of. And really the first piece of data we had regarding this was a study I was involved in. I was the urology lead on this trial. It was called Jarrard. That was published about 7 years ago now, which looked at, in men with hormone-sensitive metastatic prostate cancer, whether you could combine an active chemotherapy treatment called docetaxel with androgen deprivation therapy to see if this improved survival. And this is generally used later in the disease, but the question is, shifting it forward, did it improve outcomes? So if you combined androgen deprivation therapy and docetaxel versus ADT alone, it led to a 14-month improvement in survival. This really was a paradigm-shifting study in the way we thought about that. So this consequently led to some further investigations. One you had alluded to was whether there might be metabolic changes in these cells that could be taken advantage of. And it's interesting that these cells after androgen deprivation therapy are metabolically active. They're producing sugars, amino acids, and as a hypothesis, we had looked at a drug called metformin, which is a common drug used for diabetic control. And it's really an interesting drug in that it has, for a number of years, been not only very good at improving diabetes care, but some of the metabolic changes associated with it may be useful in slowing down or preventing prostate cancer. So we had hypothesized that if you combine androgen deprivation therapy with metformin, you might have better outcomes. We sort of approached this in a two-pronged way. One was the study that you and I did, looking at 87,000 men at the VA and comparing those men who were on metformin when they began their androgen deprivation therapy for advanced prostate cancer to those that were not on metformin. And there clearly was a lower proportion of deaths in the patients that got metformin at the time they got androgen deprivation therapy. And this has led to a trial that's ongoing right now. It's one of the arms of the Stampede trial in England, looking at this in metastatic hormone-sensitive prostate cancer. So these kinds of studies also led to some additional work in our lab looking at pathways that might be targeted. And it's interesting that glycolysis or sugar production is another area that looks like there may be advantages. We looked at in cell culture as well as in animal studies. Might be some newer drugs that which are similar to a very old drug called 2DG, which is an inhibitor of a glucose pathway. But this might be something in future that we could apply to patients, and it'll be potentially a lower toxicity approach to improving cancer care.
Yeah, it's really fascinating how you can see the sort of the research process work where you do these large health services, big data studies where you see, they're hypothesis generating, you see a signal there, the patients on metformin clearly did better. You follow that up, simultaneously you do the studies in the lab, you see, translational evidence that there's a signal, and then next up clinical trials in humans. I think that's the sort of the research cycle spinning. And it's been really cool to be part of that. And I've enjoyed, partnering with you, Dave, on those studies. You've got the lab science down, and, you understand sort of those pathways very, very beautifully. Other than the Charted trial, which I know UW was a big site for that. That's the neoadjuvant docetaxel trial in men with advanced prostate cancer, right? Bringing that docetaxel earlier up in the disease process. Are there any neoadjuvant trials ongoing at UW that are for men with more advanced but localized prostate cancer?
Yes, this question of neoadjuvant therapy is one that has been nibbled at over the years, but it's not really been used for prostate cancer routinely. Interestingly enough, some colon cancers, more locally advanced colon cancers, and with the fact that we're seeing more of these higher risk prostate cancer patients, the question is whether we can treat patients with some approach that will shrink down the cancer, get rid of the micro metastases that might be present, and improve outcomes. And there have been a number of trials we've run here, one using the approach we just discussed, docetaxel and androgen deprivation therapy in patients with high-risk cancer before surgery. And that study really demonstrated that you can decrease what we term the positive margin rate in those patients. So when a surgeon goes in to do this kind of operation, we're basically looking to remove the cancer as completely as possible, and having negative margins is an important part of that. But the second aspect of that study was really trying to understand resistance. And that's a major question is, how can these cancer cells not only survive androgen deprivation therapy, and we talked a little bit about that, but this combination of ADT and docetaxel. So there have been a lot of studies that colleagues of mine have been working on looking at this issue of resistance. So that was one trial. Another, and this is a good segue into sort of our next topic here, is a very exciting trial that we're running using a anti-cancer vaccine in a neoadjuvant approach. So this is a multi-arm trial. It's funded through the Department of Defense, as well as funded through a recent large grant that we have obtained. But the question being whether this might be another approach to improve outcomes of patients.
That is a good segue. I could talk about prostate cancer with you all day, but we're going to have you back for season 2. We've got many more topics of interest, I think, to discuss. But for our last topic, the UW team was recently awarded a large grant from the National Cancer Institute, a Special Program of Research Excellence, or SPORE grant. There are currently only 6 of these funded grants in the country, making UW one of the premier sites for prostate cancer treatment innovation in the country. So congrats first off on that huge accomplishment. And as PI of the grant, Dave, can you just tell us about this initiative and sort of what it means for the Department of Urology, but also the entire field of prostate cancer?
We'll say that was the heaviest grant I've ever, you were talking about a big lift, but the heaviest grant I've ever written. It was about 1,200 pages. So
wow,
imagine that. But at any rate, it is a real exciting development here for the University of Wisconsin program. Its goal is really to conduct interdisciplinary and the translational research that really exploits some of the strengths we have here and our national connections to improve outcomes for patients with prostate cancer. This SPORE is really going to align our strengths in basic research, and we have a huge campus where there are a lot of outstanding investigators with individuals that are working clinically to provide new avenues of care for men with advanced prostate cancer. Some of these strengths include in imaging. We really have an outstanding imaging group here in immunology, bioengineering, as well as obviously clinical care. So there are a couple of different projects that are going to be developed, and we can perhaps talk more about these in the future. But one of the projects is really focusing on the tumor microenvironment. It's really an understudied area when it comes to evaluating and targeting advanced cancer. And I mentioned this issue of resistance in cancer. And clearly, it's not only the tumor itself, but it's the environment that it's in can play a role in this resistance. So one of the projects has to do with looking at this seeing whether we can target the area surrounding the cancer to help improve outcomes for men with high-risk cancer. Another project is actually looking at cancer therapeutics, harnessing the immune response. And this is using this androgen receptor vaccine in patients with locally advanced prostate cancer to see if we can treat them with this before surgery to improve outcomes. And so this is actually a clinical trial that we're rapidly accruing to, and a number of patients are involved with it. And there's some really very exciting preliminary data coming out from this. And then one of the other projects is looking at, again, this issue of treatment resistance in more advanced prostate cancer, and really an underappreciated aspect of cancer resistance. So when patients develop advanced cancer, we'll often treat them with a chemotherapy drug. And it's really fascinating because several of my colleagues who are really experts in imaging have been able to demonstrate that if you look at somebody with a number of different areas, spots of cancer, that a lot of the spots actually continue to respond to these treatments. It's only a few of the spots that don't. And so with some novel quantitative imaging approaches, they're able to pick out these little areas that have stopped responding, and rather than taking the patient off the whole treatment, you can leave them on that. And we're actually targeting with radiation therapy just those spots that have stopped responding. So it's really a very different way of thinking of treatment failure. So those are just some of the highlights of projects that are going to be involved with this SPORE, which, as I said, we're very excited about.
Yeah, just fascinating. And I think when we have you back in season 2, we'll have a whole episode on the SPORE grant and all that. We can dig a little bit deeper into each project because it's just tremendous what you guys put together. And congratulations. This is just a huge accomplishment. I think the culmination of just a great career. So are you ready for the joke, Dave?
Lay it on me.
All right. So why are urologists great at sorting out your internet connection?
Okay, there's going to be something to do with urine, but go ahead.
They can get anything streaming. So I'm hopeful that we can get our podcast up and streaming, and people will be listening all over the country, all over the world. I think this has been just a great episode. I've really enjoyed the discussion, Dave. And once again, our guest is Dr. David Jarrard, a professor here in our department. I'm Kyle A. Richards, the host of our WInnovations podcast. I want to thank our department, Dr. Steve Nakata. Unfortunately, we're out of time. Sandra Miller is our producer and editor. And I hope you tune in for our next episode and have a great rest of your day.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.